My name is Dr. Ricardo Migliore. I'm a head of cardiology department from the Hospital Eva Perón in San Martín, Buenos Aires, Argentina. With regard to the patients with heart failure, the first point is to take in account the ejection fraction, because we have two types of heart failure. Heart failure with preserved ejection fraction. In this case, the ejection fraction is more than 50%, and patient with reduced ejection fraction. In this last group, the clinicians need to take in account that there are several drugs that could improve the mortality in about 20% of the patients. And these drugs are first the vasodilatators like ARA and enalapril, for example, and the second group is the beta blocker, in which, for example, carvedilol and bisoprolol are the most effective. And the third group is the aldosterone. With these three drugs, all the patients with heart failure improves the prognosis. But there are other medications that must be taken account. For example, in the case of the treatment of acute heart failure, in some cases there is need to add furosemide, and is the drugs of the first choice in case of acute heart failure. In another situation, for example, patients with ejection fraction below 35% and New York Heart Association functional class 2 to 3 is the recommendation of the implantation of cardio defibrillation. This can improve the survival of these types of the patient. In other case, for example, when there is desynchronicity in patients evaluated by echocardiography or another technique, or in case of a patient with New York Heart Association class 2 to 4, it could be evaluated for the evaluation of resynchronization plus defibrillation. This therapy could be as a middle point to a bridge, or as a bridge to the transplantation patient. That is the last step in the treatment of heart failure. In our country, we have some etiology of heart failure, like is Chagas disease. And this disease, when in its form, has some development of myocardiopathy with the form of dilatation. We need to evaluate if the posterior wall of the inferior posterior wall has fibrosis, because if it could be the case, the resynchronization could be improves the functional status of the patient. Another aspect to take in account is that after the patient leaving the hospital because he was compensated, you need to assess some tips about how the patient could recognize some advice of the heart failure enhancement. For example, some patients could not detect our short of breath, and only when the patient arrives to the hospital they describe it. It's important to instruct the patient how could be the symptoms and the signs who develop the heart failure enhancement. For example, the edema in the lower limbs or the cough could be a sign of heart failure descompensation. You must take in account that a patient with heart failure in general is an older patient and has a lot of comorbidities. And as a clinician, you must take in account this comorbidity. For example, it's very common the diabetes, the chronic lung obstructive disease, And you can take in account that short of breath could be caused by heart failure or by pulmonary disease. And this is very important in this type of patient. Another aspect is the frailty, because some of these patients couldn't live alone. In general, they have some problems to take or put his own medications. And with daily activities, in general, they are not independent. Some tips could be assessed with regard to this point. For example, how can you evaluate the cognitive function of this patient or the independence in daily activity of her daily lives. Only with the interrogation you can take an account of the cognitive function and how they could perform this activity. Another aspect is how to perform some types of study in this patient. You must take in account that the heart failure could be secondary to hypertension, could be secondary to ischemic heart disease, or could be secondary to valvular heart disease. And you can take some patients with mild to moderate valvular heart disease in combination with myocardial heart disease. In general, this is a problem because you need to measure how the muscle contributes to the symptoms to the patient and how the valvular problem contributes to these types. For example, one association that is very common is aortic stenosis with mild aortic stenosis. For example, an aortic valve area of 1 centimeters square to 1.5 centimeters square, a moderate aortic stenosis, but with heart failure, with ejection fraction of 30%, for example. And in this case, if the patient has, for example, ischemic heart disease in association, it could be a candidate for surgery for aortic valve replacement and for coronary artery bypass for this case. In another situation, you can take in account that the valvular load, for example, and a moderate aortic stenosis for one patient could be a heavy weight for a left ventricular with ejection fraction decrease. Similar to when the patient has a severe aortic stenosis and an ejection fraction normally. And in this case, the last treatment for aortic stenosis, for example, the TAVR could be an option for this type of patient. There is another medications that you can take in account, especially in patients with has a descompensation too frequently within internation in hospital, for example, once a month, and is an association with sacubitril and valsartan. This association proves that is better in taking account the mortality in patients with heart failure than enalapril. And you must put in the treatment of the patient, previously discount the vasodilator therapy and start with low doses of the association of sacubitril and valsartan. In the case of my country, I need to take in account if the patient has any insurance, because the cost of these medications is high for patients without insurance.